Let's move on to the gastrointestinal causes of acute pelvic pain. One of the most common is acute appendicitis, which classically presents with anorexia, low-grade fever, and diffuse periumbilical pain. Now, within 1 to 12 hours, usually around 4 to 6 hours, the pain becomes localized to the right lower quadrant. However, the pain can be variable in location, and this depends on the location of the appendix. So in patients with a retrocecal appendix, they may present with flank or back pain. Patients with a pelvic appendix will present with suprapubic pain. And if patients have malrotation of the colon or a mobile cecum, in fact, the pain can be almost anywhere in the abdomen or pelvis. On examination, there is right lower quadrant tenderness plus rebound and guarding, usually a moderate leukocytosis. If the appendix perforates, patient will present with more severe and diffuse right lower quadrant pain, although occasionally, once the appendix perforates, the patient indicates that there is no longer severe pain. In women of reproductive age, the diagnostic error rate is greater than in men, and up to 40% of cases are misdiagnosed because gynecologic conditions may simulate acute appendicitis. This is why I have always argued that when we do pelvic sonography, we should look not only at the uterus and the adnexal structures, but also at the gastrointestinal tract structures that live in the pelvis. So in acute appendicitis, the sonographic findings are a normal appendix will look as a tubular blind ending structure arising from the base of the cecum, typically on the same side as the ileocecal valve. How often is it visualized on ultrasound? Highly variable from 0 to 82%, which reflects the operator experience and location. If the normal appendix is out of the field of view of the transvaginal probe, we won't see it. Now, the abnormal appendix on sonography is defined as one that is greater than 6 to 7 millimeters in cross-section from serosa to serosa. Keep in mind that the normal appendix, unlike the small bowel, is aperistaltic, but it should be compressible on ultrasound, and it should be surrounded by homogeneous, non-inflamed fat. Often one can detect visible gas bubbles in the lumen. In acute appendicitis, the inflamed appendix is enlarged and surrounded by hyperechoic inflamed fat, just as it is in pelvic inflammatory disease, and it will be hyperemic on color Doppler sonography. The detection of a fecalith is highly suggestive of acute appendicitis. In women, transvaginal sonography is an important complementary tool to right lower quadrant compression sonography, and also should be kept in mind when CT is indeterminate. Now, when the appendix extends infromedially into the right adnexal region or the cul-de-sac, as it does in approximately 21% of women, it is ideally imaged by transvaginal sonography. Now, with the transvaginal probe, one may not be able to compress or see the entire appendix, but high resolution of the transvaginal probe allows identification of bowel wall layers. If we notice that there is a lack of continuity of the echogenic submucosa, it suggests mural necrosis and impending perforation. And here's an example of acute appendicitis on transvaginal sonography. Here is a sagittal view through the appendix posterior to the uterus. This is a transverse view. We're measuring this appendix here medial to the iliac vessels as 8 millimeters. We see that there is a fluid-filled appendix. This is the proximal aspect, which we're not seeing quite as well. And here is the rounded appendiceal tip. So this appendix is early inflamed and early in its course and hyperemic. Now, in this case, we have a slightly more severe acute appendicitis, and here we see it on transvaginal sonography. Notice that the hyperemia is more severe, and look how close this appendix is located to the right ovary. So here is the right ovary, here's the appendix, and there is the uterus. I mentioned before that high-resolution sonography using the transvaginal probe can detect the various layers of the bowel wall. In this example of a more advanced appendicitis, we see transabdominally the psoas muscle and a hypoechoic structure that no longer has bowel signature. We've lost the echogenic submucosa, and this suggests mural necrosis as well as impending perforation. Another example of a perforated appendix. Here is where we see the normal echogenic submucosa. More distally, we have lost the echogenic submucosa due to perforation. This 65-year-old woman presented with right lower quadrant pain. Review of her CT demonstrates what appears to be the origin of the appendix, but the question is, what is this soft tissue structure more deeply in the pelvis? It was unclear whether she had had an oophorectomy. This is the terminal ileum, and here are some small echodent structures, uncertain whether they represented surgical clips or something else. Well, we could say, what is the next step in the evaluation of this woman? Should we do a barium enema? Should we bring her back for a follow-up CT in 24 hours? Go on to a pelvic MRI? Or proceed directly to transvaginal sonography? Well, given the title of this lecture, we know that the answer is transvaginal sonography, which can be extremely valuable in women with appendicitis. The pelvic appendix is accessible by transvaginal sonography for both diagnosis and abscess drainage. And here we see clearly that she had a tip appendicitis. The tip of her appendix measured 18 millimeters in diameter. Notice the loss of the bowel signature and the early phlegmonous fluid collection near the tip. This is an example of a woman with a persistent, dull right lower quadrant pain. Initial transvaginal sonography demonstrates calcification in a degenerated myoma, as well as in an abothian cyst. We see this tubular structure in the right adnexa. Here it is. This was considered a possible hydrosalpinx. She did not have signs of acute peritonitis, and she continued to complain and finally had a CT scan. We see her calcified myoma, and again we see this round structure with a soft tissue rim and fluid on the inside. This was an appendiceal mucocele secondary to a cyst adenocarcinoma of the appendix, which could mimic appendicitis or a hydrosalpinx. Remember that tubular structures may be related to the tubes, but in women they may also be related to other tubular parts, such as here the appendix.